In the older macroids, what I have, it is endocrine. Just they mention and they write some of the line over there. But in new book, there is maximum too much given in the endocrine system. So this system itself is not that easy system, because whenever patient comes to hospital or patient comes to the emergency, and this one system is really very difficult to deal. Okay, if somebody comes with the diabetic and all, that's all right, we frequently do that, that could be easy for us. But if a patient comes to the other endocrine involvement, and it's really difficult to find out in emergency itself, because we should go through the lots of test investigations and history, so many things, and patients should be educated, because they should, at least they should be able to explain their problem, or they should know about their family history, medical history, past history. But unfortunately, what happens, sometimes patient comes with the little knowledge about their disease, because they never been to hospital before. But this time they land up in emergency or OPD, and they say that I don't know, I was all right since this is my first visit to hospital, I never been to hospital. They give this kind of history, and it is really difficult. So we go through it. I don't talk much about this all. I will just jump into the subject, and because I feel this is really lengthy, and another next class also lengthy, and CNS is totally very much. How can I explain within a one session? I don't know about CNS. Now next is okay, endocrine glands. Normally, why endocrine exocrine glands secretes through the duct, and endocrine glands is release hormone itself in blood circulation, and that hormone goes to the distinct site and work as it works. So it is called endocrine glands. What happens? It directly releases hormone to the blood. So disease, how disease can happen in this system is either because of the increased hormone or by the decreased hormone. It by the number of the hormone secretion. There should be the exact amount of hormone what is needed to regulate the outer body. But whenever there is the increase or decrease in the hormone production, or target is hypersensitive, hyposensitive, or resistant to the hormone, then we get the problem. There are so many endocrine glands. You must be knowing, because you are in a basic science now. I think you have finished up your basic science, so you know about this all: pituitary gland, thyroid gland, adrenal gland, gonads, parathyroid, and endocrine pancreas. So these are the endocrine glands. So we deal mostly in this topic, as well as in our life, in our practice. So the common clinical features, I just say that I am not going to read out these all. You can find out in your book also. This that is a macroid, and in macroid, what people, how people present with the patient gives symptoms of tiredness. I'm tired. I'm usually previously I used to be very strong and I used to work for a long, but nowadays I feel so tired. I lost my weight, or I gained my weight, or they say that I'm frequently I'm having diarrhea, loosey stool, and difficulty diffuse neck swelling, polyuria, excessive thirst after polyuria. They drink a lot and they pee a lot. And hirsutism, there is a male pattern facial hair in a female, and there is sweating, flossing. This all type of, some people comes with a disturbance in the menstruation regulation, and there is they say that usually I used to have a monthly regular menstruation, but nowadays I'm having my frequency changed. I have a problem in this all. They oligomenorrhea, or they say that this is less blood I see nowadays. And some people comes with erectile dysfunction, muscle weakness, and bone fragility and fractures. Okay, that depends with the what kind of problem is there. Sometimes there is a hypothyroidism, sometimes there is a hyperthyroidism, diabetes, hypopituitarism, or sometimes they have the Cushing syndrome. And so we need to go for evaluation and investigation. So we talk about thyroid gland. As you know, this is butterfly shaped gland. It is in front of the neck, as we all know, and it gives two type. Either it gives thyrotoxicosis because of the increased hormone, circulating hormone. It gives Graves' disease, most common that is, and this is autoimmune disease. Typically, mostly seen into the female, because Graves' disease is female to male ratio is 6:1. If 6 female, that's only the one male guest. Sorry, any problem? Hello, please. I don't need any disturbances. Times more common in the woman, usually presenting between 30 to 50 years of age. Also causes the toxic nodular goiter, solitary toxic nodules, thyroiditis, inflammation of thyroid, and excessive thyroid hormone injection. Sometimes what happens, patient is okay, they are having the strong problem of hypothyroidism, and they are taking the thyroid hormone. But instead of taking 1 and 2, they take excess and they land up into the Graves' disease, thyrotoxicosis, more hormone. Because of the more hormone in the blood, there is a more clinical symptom as well as problems because of more hormone injection. So there is a hypothyroidism. This is definitely, this is the hypothyroidism also caused by decreased level of the hormone, circulating hormone. This is due to the Hashimoto disease, autoimmune problem. So thyroid gland is disrupted by autoimmune. So this problem we'll see in the female more, in the male than the male. Sometimes it is iatrogenic, means it is caused by radiation therapy or surgery. Sometimes what happens, patient with the nodular goiter thyrotoxicosis, patient go for the treatment. Sometimes we go for the surgery and we take much more amount of the thyroid gland to make it produce less hormone, but we take out ample number of the thyroid glands. So later on, we'll end up in hypothyroidism, and that patient needs to take medicine whole of her life. Sometimes because of radioiodine also, there is more follicular destruction of the thyroid gland. Because of that also, there is a hypothyroidism. In that condition, Graves' disease patient is treating by radioiodine or by the surgery. We take out much more amount of the thyroid gland, or there is a much more destruction of thyroid follicle by radioiodine, land up into the hypothyroidism. So what are the history suggesting hypothyroidism? Asked about fatigue, poor sleep. Patient comes with a fatigue, poor sleep, tremor, heat intolerance. Patient says that I cannot tolerate heat. Previously, I used to tolerate heat, but nowadays it is too hot for me, and excessive sweating, hyperhidrosis. And there is they say they complain about the pruritus, itching and loosening of the nail from the nail bed, hair loss, irritability, anxiety, emotional liability, dyspnea, palpitation. They are feeling their own heartbeats, ankle swelling, weight loss, hyperphagia, fecal frequency, and diarrhea, that is loose stool, and proximal muscle weaknesses. There is really difficult to stand or from the bath or sitting. They cannot stand as they used to do earlier. They feel the weaknesses or that is proximal myopathy, because of more hormone. Even somebody is taking more steroid, also we can see proximal myopathy on them, that kind of patient also. Oligomenorrhea, amenorrhea, and the eye signs like grittiness, excessive tear, retroorbital pain, and all. In hypothyroidism, that's just opposite of that. Same fatigue is there, mental slowing, depression. Hypothyroid patient comes with the depression. So any patient with the depression nowadays, there's regular investigation for thyroid function test. The psychiatrist first go for the thyroid function test. They want to find out, is there any problem with the thyroid? If there is hypothyroidism, there's a lesser hormone from the thyroid gland, even that patient gets depression. So nowadays, routine investigation is thyroid function test for depression patient. So cold intolerance, what they say, I feel too much cold. Their friends are okay with that much of a cold, they can tolerate. But patient says, whoever having hypothyroidism, they say, I feel lots of cold, I cannot tolerate this and all. Weight gain, constipation, symptom of carpal tunnel syndrome, and dry skin or dry hair. And then past medical and drug and family and social study, we have to ask about the neck irradiation. Is there any neck irradiation or not? Risk factor for thyroid malignancy. If somebody gets the thyroid by irradiation also, they get the thyroid malignancy, or irradiation because of irradiation also, there is hypothyroidism and thyroid problem. And recent pregnancy, postpartum thyroiditis usually occurs in the first 12 months. So you should not forget to take history about pregnancy, as there or not. And then drug therapy, antithyroid drug is somebody is having carbimazole, methimazole, radioiodine therapy, or other drugs like amiodarone and lithium. amiodarone and lithium. Lithium is used for bipolar mood disorder. Some people are having bipolar mood disorder and they are in the mood stabilizing drug like lithium taking for a long time. If they are not going for any investigation like thyroid function test, kidney function test, and there could be a chance that they land up with hypothyroidism. Thyroid is not working because of drug, and kidney failure because of drug. So they regularly, usually if they are taking medicine regularly, annually, sometimes 6 monthly, they should go for renal function test and thyroid function test. And somebody is having taking anti-thyroid drug for a long time, that also they can also land up into the hypothyroidism. And the family of thyroid or autoimmune disease, if there is a history of autoimmune disease in family, there could be the chance that there could be the chance for thyroiditis or Hashimoto thyroid, like Hashimoto thyroiditis, because that is due to the autoimmunity. And residents in the hilly side, some before we used to get lots of people with the thyroid swelling, and later on Nepal government started to supply fortified salt with iodine. Iodine, we say that iodine. Why iodine? Because iodine is there. So they used to fortify that one. Fortification means adding those things. Sometimes the vitamin A also added, or sometimes iodine is added. Fortification is done by Nepalese government to subside that thyroid swelling, and that problem is now we cannot get lots of people with the thyroid swelling. Already in the 40s, 30s, we used to get lots of people with the thyroid swelling because of the iodine deficiency. Then take the history of smoking and increases the risk for the ophthalmopathy. And the feature suggest of Graves hypothyroidism. Hyperthyroidism, it is mostly in the female sex. Priority episode of the hyperthyroid requiring a treatment. Family history is there of autoimmune disease and ocular symptom we get. And physical vitiligo, pigmentation, and thyroid acropathy, and that is shown here. What is that? That is swelling of the disease to periosteal reaction of the extremity bone. So yeah, here is a picture, that X-ray picture is kept here. Later on, I'll show you other picture. And then diffuse thyroid enlargement can be nodular and thyroid brood and a peritibial myxedema and sign of Graves ophthalmopathy. I'll show you that. So many clinical features of hypothyroidism are due to the myxedema. What is myxedema? Is non-pitting edema. We cannot make it depressed by pressing for a certain time. So it is due to the tissue infiltration of mucopolysaccharides, chondroitin, and hyaluronic acid. Other findings are goiter, swelling in the neck, cool, dry, and coarse skin, bradycardia, delayed ankle reflexes, and slowing of the movement. Right. So examine sequences, observe the facial appearance. So here is the one picture. So facial appearance, how it looks is a dry, coarse hair and a periorbital puffiness. Here is periorbital puffiness, and hair, skin are dry and brittle, and puffiness of the face is there. So inspect the hand for vitiligo, thyroid acropathy, and onycholysis. There's a painless falling of the nail from hand, loosening of the nail, and a palmar edema, redness. I'll show you the picture. The palm looks very red, and assess the pulse, tachycardia, atrial fibrillation, bradycardia sometime, and the blood pressure. So escort the heart for the mid systolic flow murmur we can see in hyperthyroidism. Inspect the limb for the coarse, dry skin and peritibial myxedema. So deposition because myxedema because of deposition of mucopolysaccharides, chondroitin, and hyaluronic acid. So look for that all. And thyroid gland examine sequence. Inspect the neck for the from the front, from the side, and from the from the front and side. Give the patient a glass of water and ask them to sip or swallow that one. The thyroid gland moves with deglutition. Whenever they sip or deglute, then engulf something, then it moves up and down, right? That is the thyroid gland. Right? Palpate the thyroid by placing your hand gently on the front of the neck and your index finger just touching while standing behind the patient. So here we already discussed about this all. What is there in hypothyroidism and what is there hypothyroidism? right? So these are some pictures here. This is the Graves' faces. How face looks in the Graves' disease, and this is severe inflammation of the thyroid eye disease. There is a redness inflammation. There is exophthalmos. See, seeing the more visible sclera, white part of the we cannot see. Otherwise, this much or half of this is occupied by the eyelid, upper eyelid. But Graves' disease patient presents like this way, like a frog eye. And then whenever patient comes, you suspect about there could be the Graves' disease or hyperthyroidism, and that is thyroid acropathy, and that is pretibial myxedema, deposition of conotrate, hyaluronic, and acid and all. So conotin sulfate, this all deposition of this and looks limbs to be very ugly. And here vitiligo, I already said that there is a vitiligo hyperpigmentation area. There's a vitiligo due to the thyroid gland, and this is ankylosis because of loosening of the nail bed, falling of the painless loosening and falling of the nail from hand. That is the condition. This is palmar erythema, redness, red hand, palmar erythema, and this is what is thyroid acropathy. Thyroid acropathy, see swelling, big things, and swollen. Then digits are here. Even in actually, we can see the changes over there. So the patient's neck should be slightly flexed to relax the sternocleidomastoid muscle for the examination, and the patient will swallow again and feel the gland as it moves up and down. So what happens? Flex neck, relax this one, sternocleidomastoid muscle, and examine from behind and from behind. And this is we are examining. So what is lymph node, scanning lymph node, cervical lymph nodes, and note the size, shape, and consistency of the goiter and feel thrill. Maybe sometimes there is thrill because of the huge blood supply to the gland. And palpate the cervical lymphadenopathy. Lymph nodes, you need to palpate the lymph node also in that time. And you percussion is done for the retroexternal extension of goiter. Sometimes what happens? It goes to retroexternal. So we should percuss this one. What's called for thyroid blood. If thyroid is supplied by the ample amount of the blood to the gland, then we can we can listen blood. But sometimes what happens? It is because of the aorta also, but it is more louder than usually we get in a thyroid gland. It is more louder and along the line of the artery. So we have to distinguish it from thyroid or is a carotid one. Or the simple goiter is symmetrical, later on it may go into the nodular one. Sorry, what happened? Hello? Is any problem? Hello? Is there anyone? Okay, do you just listen? Don't disturb in between, because I'm going in a flow and you just disrupt me in between, and it's really difficult to concentrate again. Because why I'm in hurry? Time is ticking. If they give me the 3 hours, then I can teach very nicely. So diffuse tenderness in a typical of viral thyroiditis. What happens? Diffuse whole organ pain, diffuse tenderness is there. Then we have to suspect a viral thyroiditis. If virus inflammation, thyroiditis is inflammation by virus, or autoimmune thyroiditis is inflammation of thyroid by autoimmune or by viral. Sometimes what happens? People get the viral thyroiditis. That time whole gland is attacked, whole gland is inflamed, whole gland is involved. So we get the diffuse type of tenderness. But if there is a localized, only one part of the gland, one side of the gland, or top part of the gland is tender, then we should think about maybe that could be because of bleeding into the thyroid cyst. So we have to scan, but we have to do the thyroid scan on the USG of thyroid, all to find out for cyst is there or not. And we can find out, but we can suspect there could be the bleeding in the cyst of the thyroid. Then it is then viral thyroiditis, because in a viral thyroiditis we're going to have a diffuse one. And fixation of thyroid gland and surrounding structure. If while sipping a fluid, if there is no movement of the thyroid gland while palpating, also there is no movement of the thyroid gland, is fixed to the deeper structure with the lymphadenopathy, then we should suspect about malignancy of thyroid gland. So I examination also very important in the thyroid gland. We examine for periorbital puffiness, edema, lead retraction, and lead lax and all. So it looks, see, this is lead retractor. Lead is retracted. It's looking there, looking down, the lead is not coming down. It is retractor up. Sometimes because of this, people get the corneal alteration, and this exophthalmos, and there is what is peri-orbital puffiness. So this all also give us clue that this patient is suffering from thyroid disease, and exophthalmos is this one, exophthalmos. So investigation of thyroid disease, what we do the investigation? Simple nowadays we do is thyroid function test, TFT. We look for the free T3, free T4, and TSS. Free T3 and T4 is produced by thyroid gland, and TSS, thyroid stimulating hormone, is produced by the pituitary. If there is a low amount of the thyroid hormone in the body circulating, then there is high amount of thyroid stimulating hormone. Because what pituitary says, okay, there is a less amount of the thyroid, means thyroid gland is not working. So it sends message to thyroid gland, means thyroid stimulating hormone. More and more thyroid stimulating hormone is there to activate thyroid gland. But if we get that one, if a low T3, low T4, and high TSS, hypothyroidism. If there is high T3, high T4, and low TSS, hyperthyroidism. This simple investigation we do nowadays is thyroid function test. Then we go for immunology, anti-thyroid peroxidase antibodies for non-specific autoimmune thyroid diseases, and we do imaging ultrasound to find out the goiter is the smooth or nodular goiter, or what is the enlargement, size, shape, for the attachment of the surrounding tissue and all, and thyroid scintigraphy to assess the area of hyper and hyperactivity, and computed tomography, CT scan. We do CT scan to find out goiter size, and surgical planning, how we do the surgery, how much amount of thyroid gland we need to take out from this patient, as well as if there is any malignant, say, extension or fixation, or there is a malignancy changes or not. For that also, we do the CT scan, and if suspicion of the malignancy, we do fine needle aspiration cytology. If that is not possible, then we go for biopsy and find out what is there. Then another gland is parathyroid gland. It is commonly asymptomatic, but it is due to the either hyperparathyroidism or hypoparathyroidism. So in hyperparathyroidism, there is the hypercalcemia, polyuria, polydipsia, and renal stone, peptic ulceration, tender area of the bone fracture or deformity, that is brown tumors, and delirium or psychiatric symptoms. So patient comes with this one. It's really very difficult to suspect, but we should suspect if other cause is not finding in this kind of patient with a psychiatric problem or bone fragility, or there is a repeatedly renal stone, polyuria, polydipsia. It gives, we have to suspect for the parathyroid disease also. No, but normally, commonly, patient is asymptomatic. Hypocalcemic condition, hypothyroidism leads to the hypocalcemia. Hypocalcemia causes the hyperreflexia or tetany, involuntary muscle contraction. But sometimes we get patient with the tetany in the emergency room because there is a there's a involuntary muscle contraction, painful, cannot flex. So patient comes to the ER with this kind of problem. More commonly in the hands or feet, and paresthesia hand and feet and around the mouth. Hypoparathyroidism most often due to the damage during thyroid surgery. What happens? If patient goes for the thyroid surgery, the doctor removes the parathyroid gland, also the damaged parathyroid hormone during parathyroid gland during surgery. But may also be caused by the autoimmune disease. Chances is there, if there is without any surgery marks, without any history, prior history of the surgery, then we should think about the autoimmune disease for this deficit or for this problem. And another is autosomal dominant pseudo hypoparathyroidism, and this kind of there is an in-organ resistance to parathyroid hormone. Typically have short stature, patient is very short, and there is shortening of these two. There is a shortening of fourth and fifth metacarpal bone, and if we say them to make a fist, and we can make out this. If we examine also, we can make out this two is short, but this is the by birth defect problem since birth. Now asks about how we take the history. They ask about the polyuria, definitely polydipsia, and abdominal pain, constipation. Patient with a hypercalcemic condition comes with the constipation, confusion, and psychiatric symptoms. Hypercalcemia, bone pain. Definitely in hypercalcemia they get the bone pain, muscle cramp, and perioral and peripheral paresthesia. They say that jhanjan garcha. I don't feel that. Somebody if touching numbness, I feel numbness. This part of the body is sleeping. They said tingling numbness is there. I don't feel properly. I don't feel how I feel in this hand. I don't feel in this hand. Say that the feeling is somewhat numb. I don't feel that. Or you go for maybe you just examine for the calcium level hypocalcemia condition comes with the tetany and paresthesia. And past medical drug history and in that patient recent neck surgery or irradiation, maybe because of the neck surgery, parathyroid gland got damaged by irradiation of parathyroid gland got damaged, and so there's hypoparathyroidism and past history of bone fracture, past history of renal stone. Frequently renal stone is there. We should think about this also. Family history of hypoparathyroidism. There could be the family history of the endocrine disease. If that is the very much important to note down this because it runs in the family. So physical examination asks the patient to make the fist and assess the length of the metacarpals, both and with metacarpal. There's a shot. Then examine the neck for the scar. If there is a previous surgery, if there is a previous surgery, previous surgery, then there should be the scar in the neck. So this is surgically damaged by doctor iterodony. Then measure the blood pressure. Then whenever measure blood pressure, in fact the cough. If that patient is a hypocalcemic, then we get the trouser sign. That is hand of the obstetrician. What it looks is how it looks is thumb adducted. Thumb goes in, adducted, adducted, not abducted, adducted. So coming inside, and the proximal and distal phalanges are extended. So it is distal proximal phalanges are extended, and metacarpophalangeal. Here is metacarpophalangeal is flexed. This type of things we get whenever we inflate the cough of BP because of carpal muscle contraction producing a typical picture of this. So test for the muscle weakness and the hypodeflexia. Look for the evidence of recent fracture of the bone deformity, tenderness. Perform urine analysis for the renal stone and hematuria. Another gland is pituitary gland. We know where it lies in the sila turcica. It has an anterior and posterior lobe, and an anterior lobe produces the adenocorticotropin hormone, ACTH, prolactin, growth hormone, thyroid stimulating hormone, gonadotropins, luteinizing hormone, follicle stabilizing hormone, and posterior part of the pituitary produces the vasopressin, antidiuretic hormone, and oxytocin. If there is a prolactinoma, more prolactin, then this is galacturia, breast milk secretion, oligomenorrhea, amenorrhea, or infertility in a woman, and reduce libido, erectile dysfunction, and reduce saving frequency means hair is not coming as how much it is to come. Hair is in men. So acromegaly is growth hormone excess prior to the puberty, presents as the gigantism, and after puberty it causes acromegaly. Asks about the headache, excessive sweating, changes in the facial feature. Asks to see the old photographs because in the old photographs they are okay. Then slowly their face and limbs are increasing very rapidly. So there is more rapid changes in their hands and face and feet gigantism. An increase in the shoe ring or glove size. But they say so. I'm frequently changing my shoes because shoe is not fitting to me because very all day I have to change my shoes. Then my friends or my sisters or my siblings like that. So ring, okay, it was fit earlier. It is not fitting now. And glove size, associated medical conditions, arthropathy, carpal tunnel syndrome, hypertension, diabetes, and colonic malignancy, sleep apnea, and all. Take the history of this all. And hypopituitarism, apart from headache due to the stressing of the diaphragm of the sila, visual abnormalities there. Their presentation depends on the deficiency of the specific anterior pituitary. Hypopituitarism, what happens? It gives the symptom of that which hormone is compromised, which hormone is producing less by pituitary. So symptoms depends on that one. So family history, take the family history of endocrine disease. So physical examination, acromegaly examination sequence is to look at the face for the coarsening of the features, thick greasy skin, prominent supraorbital ridges, enlargement of the nose, prognatism, protrusion of the mandible, and separation of the lower teeth. There is separation of lower teeth. Some people have a separation of lower teeth without any this kind of diseases, but if we have this those symptoms, then we have to suspect. Examine the hand and feet. See, it looks very huge and big. See here, this hand and this hand. Compare this normal people and there is a gigantic people, and assess the visual field. Check BP and all, and urinalysis. Hypertension and diabetes are a more common association with this. So hypopituitarism. So looks for the extreme skin pallor, a combination of the mild anemia and melanocyte stimulating hormone deficiency. Patient looks pale, white, we can say pale type, no melanocyte, and anemic. Both are combined together. And there is absent axillary hair loss, reduced absent sexual, secondary sexual hair, pubic hair in the axillary hair. Those are there's reduced or absent, and visual field defect we can get in this kind of patient. Adrenals. The adrenal gland is definitely, you know now by now, it is above the kidney on the posterior medial surface, of course. The adrenal medulla is part of the sympathetic nervous system and secretes catecholamines. The adrenal cortex secretes cortisol, glucocorticoid, mineralocorticoid, and androgens. The history, common presenting symptoms of Cushing syndrome. Cushing syndrome is caused by excessive exogenous or endogenous glucocorticoid exposure. Most cases are iatrogenic and caused by the side effect of glucocorticoid therapy. Some patients take, some patient is prescribed steroid for a long time, and they are taking for a long time steroid therapy. Some people with the ITP, thrombocytic panic purpura, they take the glucocorticoid. Some organ transplantation also take the steroid to reduce the immunity, to alter the immunity. Those patients and no, in so many conditions, patient takes exogenous glucocorticoid for a longer period of time, and even they comes with the Cushing syndrome. And endogenous, of course, endogenous is ACTH secreting tumor, pituitary microadenoma, or maybe there is a tumor which produces ACTH in the body ectopically. That is also causes that also leads to the Cushing syndrome. And catabolic effect of glucocorticoid, white displaced tissue breakdown. What it causes? It causes white displaced tissue breakdown leading to proximal myopathy. Patient cannot stand for a long, or they need help to stand. They cannot stand easily. There is a weakness of the muscle, so that is there. And fragility and fracture, bone fracture, fragility, dry skin, spontaneous bruising. Easily you can bruise. There is a bleeding under the dermal bleeding, and skin thinning, and central accumulation of body fat. Patient may develop the hypertension or diabetes and are susceptible to infection. They are very prone to infection. Hypertension can also result from the overproduction of aldosterone. Addition disease due to the inadequate secretion of the cortisol, usually secondary to autoimmune destruction of the adrenal cortex. Symptoms are usually non-specific. Adenomas usually presents with a feature of the hormone hypersecretion. Occasionally find out when we do CT or MRI. Cushing syndrome asks about the increase in the weight. What is your weight now, increase or decrease? And particularly if weight is centrally distributed, and a bruising, easily bruising, and a dry, skin thinning, difficult rising from the chair, difficult standing, difficult to stand from sitting position, that is proximal myopathy. Then ask about the history of what kind of drugs they are taking or not. Sometimes there is they are taking steroid for a longer period of time. And addition disease asks about weakness, postural lightheadedness, dizziness. They feel the dizziness passing out. They say that I was about to pass out. I feel so dizzy, weak, and that lightheadedness, and nausea, vomiting, diarrhea, constipation, abdominal pain, and weight loss, muscle cramps. Then past medical and drug history, exogenous glucocorticoid is something patient takes that there is history of taking medicine for since a long time. And you, in the past, I think 20, 30 years earlier, there was a regulation that so many doctors used to write steroids to their patient to feel them good. So nowadays that is discontinued. And iatrogenic, that is And then physical examination, Cushing syndrome examination sequence, look at the face, general appearance of the central obesity. There may be the round moon face, right? And there could be the buffalo hump. I'll show you the picture. Examine the skin for thinning and bruising, striae, hirsutism, sign of infection or poor wound healing, measure blood pressure. Examine leg for the proximal muscle weakness and the edema. Perform ophthalmoscopy for the cataract and hypertensive retinal changes. Hypertensive retinal changes, there is retinal bleed, there is retinal hemorrhages, the cotton will exudate, and retinal hemorrhage. This kind of changes, hypertensive changes could be there in those kind of patients. So you should go for the fundoscopy also. Fundoscopy. You cannot say by like this. This is a retina. So perform the urine analysis for glucosuria. So how it looks? This is the patient before onset, and later on she got the buffalo hump. See, face changes. So face became somewhat round, moon face, something like that. She is like this before, and now she changed to this. See, moon face, I said. So bruises, easily bruises, and striae. Normally this, even pregnant women get striae during the pregnancy, but later it subside. But without pregnancy, if anybody comes with this one, with the central obesity, with the moon face, and lots of changes, then you suspect for this disease, Cushing syndrome. This buffalo hump, red round face, and high blood sugar, and high blood pressure, vitiligo, blurry vision, acne, female balding, their pubic hair loss, okay, axillary hair loss and baldness, thinning of the hair, and water retention and menstruation irregularities, emotional instability, sleep disorders, fatigue, hirsutism, severe depression. If patient come this way with this kind of changes, you suspect for Cushing syndrome. Addison disease, and examination sequences look for the sign of the weight loss and examine the skin for excessive pigmentation. There is a pigmentation. Here is pigmentation. Here is pigmentation. And if this comes, then we should think about the Addison's disease, skin pigmentation, vitiligo, because the high level ACTH increase the melanocyte stimulating hormone, leading to increased pigmentation. So diabetes now, because I have to look the time also now 3:40. Diabetes, there is type 1 diabetes or type 2 diabetes. Type 1 is autoimmune destruction of pancreatic islets. The patient is susceptible to the acute decomposition due to hypoglycemia and ketoacidosis. So type 1 starts from the young age. So it is autoimmune. There is, since the patient gets diabetes since young age, and there is a family history, as well as patient gets too much decomposition, like due to the hypoglycemia and the ketoacidosis, patient gets serious hypoglycemic episodes and all. You have to think about either could be because of the type 1 diabetes. And type 2 commonly affects the older people, and there is a family history of diabetes, as well as patient looks obese, alcoholic, and all, and fat patient with insulin resistance, and this is due to the impaired beta cell function to produce insulin. The history, common presenting symptoms are tried. In my time, when I used to do my MBBS, we used to say that polyuria, polyphagia, polydipsia. Means polyuria, lots of urine, polyphagia, lots of eating, and polydipsia is lots of thirst. But nowadays, in your book, in the macroid, now it is tried, has changed to polyuria, lots of urine, thirst, lots of thirst, and weight loss is given in your book. So I wrote this one. Otherwise, what I mocked up in my time is polyuria, polydipsia, and polyphagia. So other symptoms are tiredness, mood changes, blurred vision. Okay, right? Then there is a bacterial and fungal infection. Diabetic patient gets lots of infection in their skin. They get bacterial infection, carbuncle in their nape of the neck, in their skin. They get boil, furunculosis, and all. Lots of, because of hyperglycemia, impaired immune resistance, and tissue ischemia. Because of this, these people bound to get lots of bacterial and fungal infection. So they're itchy, they get thrush, candidiasis, So whenever patient comes with the candidiasis, then we should suspect about the diabetes also. Whenever patient comes with a frequent urinary infection, chest infection, skin infection, carbuncle, pharyngolysis, suspect about diabetes. Then it's a simple investigation. You just do the blood sugar fasting and PP. That's so easy. So past medical drug and family social history asks about the previous glucose intolerance or gestational diabetes. Sometimes people get the diabetes during their pregnancy and then it stays lifelong. Other autoimmune conditions such as thyroid disease, more bound to get this disease. If there is a history of thyroid disease, increased incidence of type 1 diabetes. Drug therapy, glucocorticoid can cause steroid-induced diabetes, and family history of diabetes, smoking habit, and the alcohol. This all because it is precipitate condition. Cause of the secondary diabetes are pancreatic disease because of pancreatitis, trauma to the pancreas, neoplasia, cystic fibrosis, and hemochromatosis, or endocrinopathies like acromegaly, Cushing syndrome. It comes along with the diabetes. And drugs like glucocorticoid, antipsychotic olanzapine, and immunosuppressive drugs also can lead to the diabetes. And pregnancy, definitely some people get diabetes during their pregnancy, and it stays there for the whole life. And monogenic defect in the beta cell function. And another way is genetic syndrome associated with diabetes. Down syndrome or Turner syndrome comes with diabetes. So routine history taking as a part of the annual review in the diabetes. Annual review. Those are the diabetic questions. If annually they come, then what you ask about? You review for the glycemic control. Ask about the frequency of blood glucose testing. How frequently he or she is testing their blood glucose level, and frequency awareness of the symptom of the hypoglycemia. And when relevant, give guidance on driving and the pregnancy preparation. If those people are diabetic, then tell them while driving they can get the hypoglycemia and they are prone to get the accident. Pre-pregnancy preparation. If mother is diabetic, it's okay. She has to take insulin. She cannot take oral hypoglycemic agent, so she has to go for the injectable insulin. As well as the baby could be the large, big one. She cannot give a birth normally, so we should prepare for the cesarean section also. All in mind makeup should be there. Then injection side, look for the injection side. There could be the lump, lipohypertrophy is a here injection side because of injection lipohypertrophy. These changes due to the insulin injection over here. Extraction insulin in there. Lipohypertrophy is done due to the insulin repeated insulin injection in this side of the body. So you look where if they are giving a thigh, look in a thigh. If they are giving the abdomen, look into the abdomen. Symptom of the macrovascular disease. What are the macrovascular? There is microvascular and macrovascular problem in diabetic patient. Whenever there is too much in insulin glucose level, then their first chances is to have a microvascular problem. What are the microvascular problem? The organ supplied by microvessels is damaged first, like eye and kidney. Those two are supplied by microvasculature. Then macrovascular is one is heart. So patient bound to get angina, myocardial infarction, this all claudication, and another is big vessel supplying to the brain. So patient are, if there is a problem due to the macrovascular diseases, then there could be the myocardial infarction, stroke, transient ischemic attack, hemiparesis, and this all caused by macrovascular. Now macrovascular is due to there could be the vision loss as well as kidney failure due to problem in the microvasculature. So feet, you have to frequently look for the food ulcers, infections, ischemia, gangrene, and ulceration of the foot, and autonomic neuropathy. Inquire about the erectile dysfunction in the men, and postural hypertension, sweating, diarrhea, vomiting in all patients. Now, this is the change in the eye. So, investigation, what we should do: fasting glucose, PP, random glucose tolerance test, HbA1c. HbA1c will do in every 3 months. It will see the condition of the glycemic control. If patient is not well controlled, then HbA1c says that this is poorly controlled diabetic. If it is goes more than 10, there is chances of having microvascular problem, microvascular supplied organ failure, as well as need for the insulin. It says urine or blood ketone measurement. This is ketone bodies. That means insulin deficiency or insulin is not functioning well. Insulin resistance is there. So another is pancreatic antibodies. We do this all. Urine analysis, urea electrolyte, kidney function test, lipid profile to assess there could be the cardiovascular risk or the stroke risk. And then thyroid function test, screen for the common STD hypothyroidism, because thyroid, if there is a thyroid problem, that cardiac rhythm is altered. And because of that, and if there is high lipid level in the blood, patient bound to get stroke or MI. So routine review of the patient of the diabetes, weight of the patient. We asked about the weight of the patient. It is the patient is gaining weight or losing weight. And insulin injection site, we look for lipohypertrophy, as well as infection, and measure the blood pressure and the pulse. So we look for the pulse and test visual acuity. Fundoscopy could be the diabetic retinopathy. So patient may lose their eye forever. Examine the feed, perform routine biochemical screening. The diabetic food early recognition of the at-risk food is essential. There will be two main presentations are like neuropathy. Neuropathy predominates, but the major arterial supply is intact. So in a neuropathy, what? He cannot feel pain, but arterial supply is there. So there is no ischemia, no gangrene. Neuroischemia is arterial supply is compromised, so there is chance of getting ischemia as well as gangrene of the foot. So we need to take care of this condition. So examine sequences, look for the hair loss and nail dystrophy. Examine screen including the interdigit cleft for the infection and all, and distal pallor can suggest early ischemia. So we need to find out that one, because there is chance of having gangrene of this patient after, and they lose their limb. After patient to stand, so that you can assess the foot arch or the deformity of the joint of the feet, feel the temperature of the feet. So assess dorsal column function by testing vibration and proprioception. Undertake a foot risk assessment to the guide the management. Hair loss and nail dystrophy occurs with ischemia. Loss of the sensation to vibration proprioception are early sign of diabetic peripheral neuropathy. And severe sensory neuropathy is present if the patient cannot feel the monofilament on the side. That suggests loss of the protective pain sensation and is good predictor for the future ulceration. Right. So there could be the food changes, and there is a rock bottom food. So with significance in neuropathy, the foot arch may be excessive. Sometimes what happens? Arch is excessive. There is more arching or collapse. Here arch got collapse. This changes due to diabetes. The more arch, less arch, and these are called rock or bottom sole. Both condition causes abnormal pressure and increase the risk of the plantar ulceration, particularly in the forefoot. So it changes more pressure, it gives more pressure, and there could be the chance of ulceration. Here is difficult to walk, so we need this kind of sole to fit here. So they said there is fissures and all. So yeah, here is a risk estimate of the diabetic food. I'm not going to talk about this all. So need to revise every year about the food condition. This could be seen by specialist and assess for the food, because there could be a chance of ischemia and gangrene. This is monofilament testing. We test by filament pain sensation is there or not. If there is lost, then there are chances of having the food ulcer, as well as gangrene later on. So these are diabetic and the skin. So skin changes in diabetic disease. I haven't taken you integumentary system. I think you missed that class in your first or second semester. It was comprised in the second semester. First semester integumentary, I taught your 23rd batch last time, last week. And there is integumentary system is the system of covering, that is skin diseases. But I kept this photo here for you all. So in a diabetic, there is changes like acanthosis nigricans. This is this hyperpigmentation of neck and axilla, and another is eruptive xanthomas, and this is necrobiasis lipotica. Necrobiasis lipotica. This is eruptive xanthomas, and this is acanthosis nigricans, hyperpigmentation of neck and axilla. So this is the skin changes in diabetic disease. Thank you. Hello. Hello.
Yes,
Hello.
sir.
Hello. Okay, Deepika, are you there?
Yes, sir.
Okay, I see 64 plus students over here. You just tell your teacher that how many attended this class.